on my watch, we are running on time. So welcome to all the attendees and guest speaker to this new IMPERAS Sarcoma educational session. I think it's the 25th session. Today we have a quite different session. It will be an interactive session between the moderator and the speaker. The moderator will be this time Dr. Jason Hornick. He's a professor of pathology of Harvard Medical School, director of surgical pathology and immunohistochemistry at Brigham and Women's Hospital in Boston. As you surely know, he's a very well recognized international expert in sarcoma, gastrointestinal mesenchymal tumors, etc. Has many contributions in pathology journal of high impact factor. Is also author of many chapters of the soft tissue and bone WH Blue books. So Jason, many thanks for your time and your willingness to participate in this session. The speakers will be free Spanish pathology. The first speaker will be Dr. Cleofe Romagosa. She is the IMPERAS lead and expertise in bone and soft tissue pathology from Hospital by the Bron, Barcelona, Spain. Just to know that Jason IMPERAS is a project whose main objective is a central review of all sarcoma diagnosis in Spain. Dr. Enrique de Álava is the second speaker. He's professor of pathology at the University of Sevilla, and he's the director of pathology department at Hospital Virgen del Rocío, Sevilla. He is also a very well-recognized international expert in sarcoma and molecular pathology. And the other speaker is will be Isidro Machado. I will combine my affiliation data at the beginning of my presentation. Many thanks for your participation in this interactive session with Jason. I will be in the background checking the microphone. Please mute your microphone during the presentation, and you may send questions or remarks by using the chat. Also, at the finish of the session, Dr. Sergio, who is the president of the Latin America division of the International Academy of Pathology, will combine some detail about the International Academy of Pathology Congress in Cancun next year. So, Cleofe, thank you. You can share and start the presentation.
So, can you see the presentation? Isidro, can you hear me?
Yeah.
Perfect. Yes? Okay, yes. And can you see everything? Perfect.
Yes.
So I'm going. I will do some questions in the middle to know about, to learn from Jason, and that's the main objective of the session. So I'm going to present a soft tissue tumor in a 13-year-old girl. It was in the thigh, it was deep, was growing fast, and at the moment of the diagnostic, the mass was 17 per 15 per 11 centimeters. Sorry, it was a consultation case sent from another center, and we received 4 different H&E stains and 1 paraffin block. This is all the material they sent together, the 4 slides. And as you can see, the aspect at low power is very homogeneous between them. All the cylinders are pink, very pink, and with lots of holes. And when we see that more closely, we can see that the samples were made by a very sclerosing matrix, and with these vascular or vascular-like structures, dissecting this very collagenized and dyelinized matrix. In other areas, we can see more densely the vascular or vascular-like structures, as you can see here. In other areas, we can see some edema. And very focally, there were very few areas like this with a spindle, more solid proliferation, and some rapio or collagen. At high power field, we can see the cells The cells surrounding the spaces of the vascular or pseudovascular structures had these relatively small nuclei, mainly vesiculous with inconspicuous nucleoli and very scant cytoplasm. And in the more spindled areas and solid areas, the cells were quite monotonous. They were organized in more or less longitudinal fascicles, but quite disorganized. And the nuclei were elongated and also vesicular with very rare and focal inconspicuous nucleoli. Initially, my differential diagnostic starts with vascular tumors. The truth is that I was not sure about what it was, but I was quite convinced that these were vascular structures. And my first thinking was to retiformium and endothelioma that can be developed in children. Probably is not frequent as a deep mass, but the structures, in my opinion, were my first thought. But the spindle areas were quite rare for that. Another option is a composite endothelioma that is very rare. It's a tumor that is not frequent. The location is not the favorite, but not impossible. And the age is not the favorite, but probably not impossible. And the hemangioma variant was very rare for me. I couldn't find the hemangioma that can look like this. And angiosarcoma can have these dissecting channels and a spindle cell proliferation, but these samples that I have not said that had very few mitotic figures, like 1 or 2 in 10 power fields. So it was not my favorite diagnostic. Because the case was sent for an expert on vascular tumors, I thought it was not a vascular tumor, or the possibility of that was not a vascular tumor. So I started to think in other options. And sclerosing pecoma could be, but the location is not the most frequent. The age is not frequent. It could be a rare case of sclerosing pecoma. And epithelioid sclerosing fibrosarcoma, I've never seen these pseudovascular structures in them, but I was exploring this possibility. I started to think in biphasic tumors like a synovial sarcoma, but I've never seen something like this. It's not impossible. The pseudovascular structures could be the epithelial structures, but for me it was very difficult because the morphology was not really in my spectrum of these tumors. And I consider potential new entities that we know that are being described every few days with the new molecular tests, or a variant of a known entity that is making me confusion. These are the immunohistochemical stainings that the reference set, the local center sent in consultation. And from them, the most important ones were the vascular markers that were all negatives, 34, CD31, and ERG. They also sent a very positive TLE1 and EMA that was very positive in the pseudovascular structures and focally, but very focally on the spindle cell areas. And pancytokeratin that were much less positive, but they show also more positivity on the pseudovascular structures than in the spindle cell areas. Moreover, we had a INI1 that, in opinion of the local center that sent the case, was mainly lost, but I was not sure, so I decided to repeat it. And the Ki67 that, as you can see, is very low, and I couldn't understand why this lesion was growing so quickly. The information that they sent said that they tried to do EWS and SIT fish but the results were non-evaluable. However, in the seed fish, they could see very, very, very few signals, and they had the suspicion that some of the cells showed a translocation pattern, but they were not sure because most of the signals couldn't be seen. They said me that if we need it, they can send frozen tissue, and we started with our panel. I decided to rule out the PEComa that was not ruled out before, and I repeat the INI one, and I add MUC4, the SS18 SSX immunohistochemistry, and B-core. I don't think that's a B-core tumor, but it's an adolescent, and it has this spindle area that could be, I don't know. The truth is that I couldn't recognize the lesion, so I opened my mind. Regarding the INI1, the staining was mainly positive, but weak, making me think that possibly it has a partial loss of SMARCB1, but I was not sure. And we have some very weak and weird positivity for desmin and HMB45 that were relatively focal and very, very, very weak. And the surprise was that SS18, SSX was strongly positive. And in my hands, this antibody is very, very specific, and in the literature either. So I started to think that I was in front of a very, very rare synovial sarcoma. We performed the FISH for the SS18 rearrangement, and it was clearly positive in more than 80% of the cells. So now my questions. Jason, if you want to give your opinion, you're welcome. Okay, my first question is, when you have the positivity for the immuno of SS18, SSX, and a seed rearrangement, we can consider that a synovial sarcoma independently of morphology?
Yeah, so it's a very interesting and beautiful case, really unusual morphology, as you say. I think that the extent of staining with EMA and keratin A1A3 in the pseudovascular component is good evidence that that's actually epithelial differentiation, which would be the biphasic component of a synovial sarcoma. So I think the morphology is very strange, but the immunophenotype fits very well. And you know, the SS18 SSX fusion-specific antibody is directed against a conserved amino acid sequence at the most common site of the gene fusion. So it's 100% specific. I have never seen a case that is positive without the fusion. And in fact, even cases where FISH for SS18 or SYT is negative due to a cryptic rearrangement are sometimes positive with the fusion antibody because it's looking at the sequence just like a fusion panel of RNA next generation sequencing or old-fashioned RT-PCR. So I regard it as 100% specific for synovial sarcoma.
Okay, thank you. And have you seen any case like this? Do you know if this pattern has been previously described? Because I couldn't find any information related.
No, I've never seen a case where the epithelial component looks so remarkably vascular. It's amazing.
Okay. And well, the other question is, there are other tumors with seed rearrangement? Actually, I had one time a case of a very pleomorphic mass that arrived to me in a second opinion, diagnosed as a synovial sarcoma, and I couldn't believe that that was a synovial sarcoma. I had nothing about a synovial sarcoma, only the result of the molecular. I repeat the molecular, and the rearrangement was there, but I couldn't diagnose that like a synovial sarcoma. it was a pleomorphic lesion. Probably it was random. This one, in my opinion, I don't know, but I want to know your opinion. Do you have an experience on that, or what do you think about that?
I have seen over the years 2 or 3 cases where the morphology was very unusually pleomorphic. I recall a case I saw on the kidney that really looked like a pleomorphic spindle cell sarcoma, nothing like conventional monophasic synovial sarcoma, and a fusion was identified by sequencing. This was many years ago, before we had the fusion-specific antibody. So I think it's very hard to adjudicate those cases without confirmation by a second method. Now that we have this antibody, I think it will be easier to decide if those really do have a functional fusion, because if they produce the fusion protein, that would be good evidence that the fusion is real. To be honest, I'm not sure what to make of the pleomorphic sarcomas that have this fusion by RT-PCR or something. So honestly, I don't know what to do with those, so I'm not sure. I will say that there is one other recently described tumor type that is totally different in the salivary gland. You might have heard of it. It was described by Justin Bishop and Brendan Dixon and others. It's this very strange microsecretory adenocarcinoma of the salivary glands that has SS18 fusion, but a different partner. So it doesn't have the SSX fusion partner. Instead, it has fusions with a gene that's totally different. So it wouldn't be a consideration. It's a totally different tumor type, but at least there is one other defined tumor with the same SS18 gene.
Okay, thank you. I think you have answered to the last question, so we can go on. I was looking for, I thought it most probably is a synovial sarcoma, but let me learn about that. And I found that there are other tumors with SSX1 fusions, but not SS18. This fusion between AWSR1 and SSX fusion, it's being described in other papers. In this paper, they propose that it's probably a new entity or a pattern or whatever, and they were talking about an sclerotic epithelioid tumor, but it was not exactly the same than our tumor, and our tumor had a SS18 rearrangement by Fish, so it's not our case. Later, the group of Yoshida wrote this paper finding the same rearrangement, EWSR with SSXX, in a group of tumors looking like a synovial sarcoma. I think that all of us can be quite confident diagnosing these cases as a synovial sarcoma. So probably the previous are part of the spectrum of synovial sarcoma. I don't know. And also, as you said, there are new tumors. This is not the one that you were talking about. This is a cutaneous sarcoma, also with SSX18 rearrangement with different tumors than SSX that are being described now. And we have very few information about these tumors. I understand would be positive for fish, but not for the immuno. And the previous, these ones would be negative for fish and negative for immuno. And we will have to look really for the molecular if we want to demonstrate that these are synovial sarcomas, going to an NGS or a RT-PCR, probably. Well, no, not an RT-PCR, because we will not suspect the EWSR1. And finally, I decided to do the NGS, not because of diagnostic, because I was quite convinced that that was a synovial, but just for understanding if there was any modification in the sequence or something that could be related to that, not than for scientific reasons. But The translocation that we found was an SS18 SSX2 conventional without anything weird. So the weird thing is morphology in this case, and is a new pattern to learn to be aware for the diagnostic of synovial sarcoma. Don't know if you want to share more opinions or.
Yeah, it's a great case. I think that the case reports and the small series that you showed are a very nice example of how, now that many laboratories run fusion sequencing, fusion panels, RNA-based on so many tumors, we are discovering a new fusion every day. And for most of these, honestly, I'm not so excited to have a case report because I don't know if it's really an entity. One case with an interesting fusion for me makes it more confusing for the world of pathology until you have a consistent histology, consistent phenotype, consistent molecular with some outcome data. One case is very hard to know what to do with. But I think in your case, as you say, this is just a very interesting pseudovascular synovial sarcoma, which for me is very clear. It's a great case.
Okay, thank you. I don't know if other people has some questions for me or for Jason or.
You have a question in the chat box.
Okay.
And so the question says, can you review the fish from the initial institution? They reported it as negative.
No, they don't report it as negative. They report it as non-evaluable. In their hands, the fish was not working. I don't know why, probably related to the protocol, because in our hands it works on the paraffin sample and it was pretty good. It had no problems. Enrique is asking if there's any prognostic significance of the pattern, but
yeah, is there any clinical pathological correlation on that, or this is just a curious morphology pattern?
I don't know. There's no. I couldn't find other cases with this pattern in the literature, and I think Jason said the same. So without cases, you cannot know the behavior or the significance of that. The tumor, what I don't understand, probably because of the pseudovascular structures, was growing very fast, and the Ki67 was very, very, very low. It's very weird. I know the girl was, the tumor was surgically treated, and I don't have more information at the moment, but I'm in contact with them. They were thinking on to do neoadjuvancy because the oncologists were very scared about the growing of the mass.
There's one more question in the chat. Do the reported cases with alternate SSX fusion with EWS, are they positive with SSAT and SSX or SSX immunohistochemistry? And I can answer that. The SSX antibody is positive because that's a conserved, that antibody recognized a conserved sequence at the C terminus of all the different SSX proteins. So that's positive, but the fusion specific antibody is negative in those rare cases.
Yes.
Another question, what do you do in cases where there is no correlation with histology and molecular results?
I fight them. I'm not happy if it happens, and I try to demonstrate that the situation is really that. Sometimes it happens and it has an explanation. And morphology, in my opinion, morphology and clinical information are the clues. Molecular can be a wrong result, can be a weird result. The chromosomes can do things, especially in pleomorphic tumors, that they do lots of things. So there are studies in MPNSTs showing that there are lots of rearrangements in MPNST that have not been detected previously to the whole genome sequencing. So probably it can happen in other pleomorphic sarcomas.
Yes,
So,
I think that's, yeah, Cleo, that's a very good point. I think that, many cancers have essentially what is noise. You can find these fusions that are not functional. So, you find a fusion by incredibly sensitive techniques that mean nothing. So I do think you have to be careful not to overinterpret the results of a molecular test that is potentially irrelevant to the case altogether. And I'm sure Enrique has a lot of experience with the same problem.
and Sylvia is asking if I had the opportunity to see the surgical specimen. Not yet. I hope to share it with them because we are thinking to write it in any. I think it can be helpful for the community to know that this pattern can correspond to a synovial sarcoma. So we are looking for the way to write it. So probably I will see it, but not yet.
This is very exciting to see the whole specimen because maybe this would be a focal pattern.
Yeah, they do lots and lots of different. I asked them if the true-goods came from the same area. They said no, but the full specimen, it was a big mass. So obviously it can have more conventional areas in other areas. And the bad thing is that I think they did neoadjuvancy, so it can change. But okay, so I think no more questions.
Stop sharing. Okay.
Let the place to Enrique.
Okay, here we are. Should we start? Okay, that will be a more usual case, and actually it's an easy one. Okay, but let me first. How can I go? Okay, this is stacked. Great. Okay, let me first greet all my fellow citizens of my hometown, Pamplona. Today is the start of the festival of Pamplona, 7 days of fun. I would like to be there. I wish to be there, but I'm of course very happy to be today with you. So let me go to the case, a very easy one. This is a 50-year-old male with a parotid gland mass. This is a consult case coming from the beautiful city of Cordoba, Dr. Sanchez Frias, and the path diagnosis was an undiff malignant pleomorphic or neoplast with neuroendocrine differentiation. And the tumor was resected, and currently there's no lymph node extension. Follow-up as of yesterday was no evidence of disease, only in 3 months. Okay, so what we let me see if I can use the pointer. Okay, here. What we see is in the ultrasonography a mass of 2 by 1 centimeters, relatively homogeneous, and the mass is here in the posterior tail of the parotid gland. You see it's a relatively well demarcated mass. So this is the mass. It seems to be well demarcated and of course close to the parotid gland and also close to the skin. It seems to have like a pseudocapsule. Sometimes the pseudocapsule is continuous, and sometimes it's not really that continuous. So it's well demarcated, but not really encapsulated. The tumor is a solid one, very cellular. It's not a small muscle tumor. This is medium-sized cells. Actually, has a sort of epithelioid appearance, medium size cells, polygonal cells, brisk mitotic activity. Some of the mitoses were atypical. And so far, does any one of you want to say, based on the clinics and the H&E, which is your first diagnostic impression? Any of you? Okay. What the referring pathologist thought, and that was my thought as well, is this is a malignant epithelial and diff neoplasm. Nothing else to say. Doesn't look like anything, right? So it expressed a lot of synaptophysin diffusely and intensely. Chromogranin, however, was completely negative. CD56 was positive, membrane positive, so it looks like nice. Again, more or less diffuse. And NLAs was positive, focally positive and strongly positive. So it looks like neuroendocrine thing, whatever. Keratins negative. You have a nice positive control, but keratins were negative in the mass. So far, based on this and the immunohistochemistry, what's your diagnostic impression? Okay, what they thought and what I thought myself when I got the case was, okay, this is a neuroendocrine tumor, maybe a malignant paraganglioma or something like this. The pathologist is a brave one. She was puzzled by the case. She said it to us, and I was puzzled myself for weeks till I came back to the tumor and looked at the H&E carefully. Well, there were some areas of necrosis or maybe apoptosis, some atypia, and some atypia again. Actually, there was some foci of necrosis, clear necrosis, so it doesn't look like a very good tumor, right? But we started to see carefully some structures that looked like vacuoles, like small glands within the cytoplasm, close to the nuclei. And we started to see them all over. This is an epithelial tumor with this nice arrangement with these vacuoles within. Vacuoles were really evident. And some of them started to show, red blood cell, and I don't know how to interpret this image. I don't know whether this is an erythroblast or this is just an apoptotic cell or what's that. But this is having to have a familial face. Eosinophil, look at this. So we ran ERG, and ERG was positive all over, positive in the nuclei with nice positive control. And so was CD31, intense and diffuse, very strongly, the membrane, so very clear, while CD34 was negative all over the case. Okay, so synaptophysin, CD56, NLAs, ERG, CD31, INI1 was retained and S100 was focally positive. And negative for chromogranin, cytokeratins, smooth muscle markers, melanocity markers, I didn't show everything, JAP1 and calcitonin. And we ran some fish analysis, WWTR1 and TFC3 were negative. Okay? So, based on this, what is your final diagnostic impression? Okay. What we thought was, okay, this is a low-grade malignant epithelioid vascular tumor, okay, with neuroendocrine differentiation. So we wanted to make a more precise diagnosis. So we ran NGS as well with the Archer panel, very popular now in Europe. And what happened? We were expecting something. And nothing actually came because there were no fusion transcripts all over. Okay, so our final diagnosis was a low-grade malignant epithelial vascular neoplasm with neuroendocrine differentiation, favoring low-grade angiosarcoma, but not very clearly, maybe not very convinced. And I want to discuss in this case three different aspects, three different things. First, the evident pitfall is well known, but I think is worth to remember sometimes that neuroendocrine differentiation in vascular neoplasms is a pitfall, and is actually a relatively common pitfall. First time described in 2014 by Andrew Volpe on angiosarcomas, showing a series of 3 cases in which synaptophysin was positive, with almost negative in almost all cases for chromogranin, CD31, CD34 negative, CD31 positive. And well, ERK was not that popular at that time, so we can rely on that. But cytokinetics were almost or mostly negative. But this is not only for angiosarcomas. In 2017, for composite hemangioendotheliomas, also a neuroendocrine marker variant was also described. They showed 11 cases of such a neoplasm, again with a peculiar pattern of expression of neuroendocrine markers, positive for synaptophysin and negative for chromogranin. And also for hemangioendotheliomas in 2021, this is a series of 62 cases in which there is a small subseries of 4 cases, by the way, showing a WWTR1 rearrangement in all of the cases, showing strong expression of neuroendocrine markers and bad prognosis all over. So this is the first thing we should discuss on this case. The second is, okay, should we go beyond targeted RNA-seq? We are comfortable running our FISH, our NGS with our panels. Should we go beyond? Why do I ask that? Okay, if we run with epithelioid vascular tumors, of course, epithelioid hemangiosarcoma, we have into flavors, WWTR1 cases and TFE3 JAP1 cases, right? But these genes are really well represented in the Archer panel, so you should pick them up, okay? By FISH or by NGS, you should pick them up, no problem. But things are becoming more complicated. Christina showed some cases of composite hemangioendothelioma with PTB, PI1, MAML2 fusions, and showing a bad prognosis and showing an involvement of the neck lymph node. So again, a bad prognostic subvariant of EHE with composite features, right? And actually, she just published another paper on MAML2 positive epithelioid neoplasms, showing a really heterogeneous disease. This gene is rearranged in many different things, like mucoepidermoid carcinoma. This is not the case, no keratins, paromas, thymomas, of course, hemangioendotheliomas, and rare nodular necrotizing variants of mixed inflammatory fibroblastic sarcomas. Okay, who knows? And she's showing cases sometimes similar to the case I showed you before. And well, who knows? I don't have a FISH probe for MAL2, so if you have one, please let me know. I can show you the case. And of course, this gene is not represented in the Archer panel. So my second point of discussion is, should we rely only on this kind of panels, or should we do RNA-seq with whole genome or whole transcriptome for sarcomas? This is something to think or to start thinking about. And although, of course, morphology remains as the cornerstone of sarcoma diagnosis over all the ancillary techniques, we have to work together in terms of harmonizing our NGS. In IMPERAS, the project that gathers today, we are in charge of the part of harmonizing NGS for the whole project, for the whole country. And our problem is to harmonize protocols with other people, measure the actual impact on sarcoma diagnosis. Again, these rare, weird fusions with no functional value, of course, they are distracting the actual diagnosis, right? And this is, of course, the challenge of discovering new fusion genes, and then, of course, to figure out which is the clinical value of them, and of course, to set up a national platform for sarcoma NGS that we are now building it up thanks to the funding of the Fundación Española, Asociación Española contra el Cáncer. And the third thing to discuss is, okay, for me, the difference between low-grade epithelial angiosarcoma and epithelial hemangioma is starting to blur a little bit, because sometimes morphology is not that different. And this is those two real cases with molecular confirmation in both of them, and they look a little bit alike. And I leave it open because I would like to know which is your opinion, Jason, and everybody else in the audience. Where should we mention, or should we diagnose this case as an epithelial hemangioma or a low-grade epithelial angiosarcoma? So, to conclude, three messages. First, I think be aware of the neuroendocrine differentiation pitfall in vascular tumors, all kinds of vascular tumors. Second, should we think on doing something else in addition to targeted RNA-seq for sarcomas? And then, okay, differentiation between hemangioendotheliomas and angiosarcomas, low-grade angiosarcomas, could be a bit tricky, and maybe fusion genes do not help us too much. So I thank my team, my sarcoma team in Sevilla, and all our funders, and of course I wish you a nice evening, and I hope to welcome you to Sevilla once. Thank you very much.
Well, thank you, Enrique. That's a very interesting case. And as you say, to be honest, when I first encounter a case like that, my hope is gone. I think here's an undifferentiated epithelioid malignant neoplasm, and it seems fairly hopeless. But as you said, when you look very carefully, sometimes you find helpful clues that can lead you at least to a specific lineage or something. So endothelial should always be somewhere in your mind if you see sheets of epithelioid cells.
Mm-hmm.
So, you know, you raised some very interesting questions. I personally very rarely run neuroendocrine markers when I encounter a tumor that looks fairly undifferentiated with a lot of pink cytoplasm. So I know there's a lot of nice literature showing especially synaptophysin staining in vascular tumors, angiosarcoma, composite hemangioendothelioma, but I think in my practice, I would never find those cases because I wouldn't run the stains.
Yeah.
So it is interesting, and it's good knowledge to be aware of, so that in practice, surgical pathologists don't make a mistake and call it a neuroendocrine carcinoma. But you know, neuroendocrine carcinomas usually have such characteristic nuclear morphology and very limited cytoplasm. So I think that's the reason I never think to run those. Your point about epithelioid hemangioendothelioma versus epithelioid angiosarcoma is a very, serious problem for us who see a lot of these challenging soft tissue tumors. And to be honest, that's one of the reasons that I very much like the immunohistochemistry for CAMTA1, because we have a fairly easy way to confirm the pathognomonic gene fusion for epithelioid hemangioendothelioma when we're dealing with the very cellular atypical examples, which are very rare. Probably only 5% look so atypical that you really start to think of angiosarcoma with epithelioid morphology. In most cases, with the characteristic myxohyalin stroma, they're very bland, they're not so cellular, you don't really need to confirm the fusion, you don't need CAMTA1 immunohistochemistry, you just have to remember it's not carcinoma, it's epithelioid hemangioendothelioma. But for the cases, as you discussed or you talked about, it can be very helpful to show the CAMTA1 fusion. For me, I think without the characteristic fusion, I usually consider those epithelioid angiosarcomas. And especially in a case like you have in this example, the degree of nuclear atypia and variability is so striking, as well as the high mitotic rate, atypical mitoses. I have never personally seen an epithelioid hemangioendothelioma with the confirmed fusion that looks as ugly as this. So for me, this is epithelioid angiosarcoma. And I think at least for my colleagues in oncology, they really do care about the distinction, even though the ugliest epithelioid hemangioendotheliomas do badly, the angiosarcomas are very chemosensitive. So although the patients eventually do quite poorly, they are, in a way, they're happier for it to be an angiosarcoma because they can treat with chemotherapy and give the patient some years of life. The aggressive epithelioid hemangioendotheliomas with CAMP2-1 fusions barely respond to any therapy, and they do very badly with no real good intervention. So I think the distinction is important.
Yeah.
With regard to your final point, certainly I think it's interesting to find the fusions, and we like to find an answer. In my practice, I very rarely run molecular diagnostic studies. I think it's very interesting, but in very few cases of a tumor such as this, does it provide very important clinical information for prognosis or management. So I really reserve studies like that for investigation, for research. I think it's a great way to discover new things, which can advance our understanding of pathogenesis and perhaps eventually subclassify tumors with more granularity. But at this point, I feel that the clinical implications are not sufficient for me to pursue studies such as you described.
Mm-hmm. Okay, thank you. Just to answer to your comments, remember that was a consult case, and pathologists at that spot were so desperate that they ran lots of immunos, and this came out. So we also were puzzled by this, and for me that was something we learned, really learned that we should get aware of this pitfall. So that's why I am sharing this, although this is very basic, right? So this is first. Second, yes, this is atypical. This is mitosis. There's mitosis. There's also some necrosis. And the reason I was a little bit reluctant to say overtly that was an angiosarcoma was the good delimitation of the tumor with respect to the gland, because there was no skin ulceration and the gland was not invaded. There was a pseudocapsule. So I thought, okay, I would expect an angiosarcoma to invade a little bit more, right? And there are some questions in the chat asking me whether should I call them low grade or high grade or whatever. I've seen some epithelioid angiosarcomas much highly mitotic and atypical. So since I was in the doubt between angiosarcoma and hemangio, I tried to be in the frontier to call it maybe low grade. I don't know whether this is an actual entity or not, but that's what I thought. And then with respect of running molecular stuff, I basically agree with you, but I also have some part of my brain is investigative. So as long as I have money and I can help somebody else in another hospital, I try to run just to figure out if I can learn anything from that. But of course, this doesn't change so far the clinical management of these patients. But maybe if you collect many cases like this will be happening in the future.
Yeah, and I think the comments about epithelioid angiosarcoma are very good. We do often feel very uncomfortable when the sarcomas really don't quite fit our expectations, and I have the same problem every day. But in general, once I've decided it's angiosarcoma, I don't grade them. And epithelioid angiosarcoma, I don't give a grade. So I think that the questions in the chat are reasonable because we don't really have great guidelines for that. There have been several studies trying to establish grading for angiosarcomas, but because they're so heterogeneous, they arise in so many different clinical contexts where the behavior is actually quite different in different settings. I still don't feel like I have enough confidence or knowledge to provide a helpful grade. So I consider them all to be high grade, even though occasional patients do very well, and that's great. But at least they seem to be chemosensitive, even when those patients do have a very good prognosis in a small subset of patients.
Okay, great.
Any other questions for Enrique in the chat? I don't think I see any others other than the grading questions.
Yes, I do have some follow-up, Cleo. I showed in the second slide, but it's just 3 months follow-up. So far, so good. But that's all I can tell you. Keep you posted.
Yeah, great case. Really, really interesting case.
Okay, thank you.
May I share my screen? Can you hear me? And can you see the presentation?
Perfect, Isidro.
Yes, great.
Okay, thank you, Jason, and to all the guest speakers and to all the attendees to be present in this session. So my case is a gastric tumor with round epithelioid morphology. I know, Jason, that you like sarcoma, but also a gastrointestinal tumor. So I select one of these cases. So this is my place of work, Instituto Valenciano Oncológico, Hospital Quirón Salud, and University of Valencia. So this is not our case for today's session, but I think that it's important to show you before my presentation. There was a case for a 46-year-old female with a gastric tumor. The radiology suggests yeast and really looks like yeast, at least in these low power fields. And in the second, in higher power field, as you can see here, yes, it could be yeast, but it looks like round or epithelioid morphology, not very frequent in yeast. So, but we immediately request CKIT, and it was strongly positive, and also DOT1. And our diagnosis was this, and the molecular diagnosis was this tumor revealed KIT mutation. So any doubts that this case represents gastrointestinal tumor. Now, this is our case for today's session. This is a 49-year-old woman with abdominal disconform and dyspepsia. An endoscopy and abdominal CT scan was done. I'm sorry, I'm not a radiologist. I try to do my best to show this imaging. But this was suggested as fair diagnosis. That is the echoendoscopy. As you can see here, the tumor for 4 centimeters of diameter. And that's it. You can see in the endoscopy the tumor that looks like a submucosal tumor with ulceration. There was performed a biopsy, but there was no informative, as usually occurs in submucosal tumors sometimes. This image was provided by Dr. Javier Lavena. This is an oncology who is in charge for this case. So this is the abdominal CT scan, and you can see here this large tumor apparently depending of the gastric mass, the gastric mass, with some areas looks like necrotic areas. And this is the morphology of the tumor. This is a macroscopic imaging. The tumor was operated outside the hospital, and this is the macroscopic imaging, kindly provided by Dr. Carmen Medina. As you can see here, the tumor Well, it's confirmed that this is submucosal tumor. This is no news. We know this from the imaging. And the morphology at low power field, you can see here a diffuse chip of growth tumor. And at higher power field, you can see here that the tumor looks like round epithelioid maybe, but not a spindle cell tumor. So this is higher magnification, and you can see here in more detail the nuclei that sometimes remind the growth. This is growth that characterize the Langerhans cell histiocytosis, but the tumor looks like with nucleolite. The nuclei was evident, and the nuclei were very monomorphic. So this tumor looks like fusion-driving tumor by this monomorphism appearances. In these other fields that you can see the tumor with more epithelioid morphology, maybe you can see here more cytoplasm in this tumor. And however, another areas show something like giriform pattern that can remember sometimes this granular, the granulosa cell tumor from the ovary, but with giriform tumor and more round morphology, as in this other field of the tumor with this maybe pseudo-rosette or try to form a pseudo-rosette formation. And as higher power field, you can see here in more detail the morphology of the tumor with shiny. And this is the higher power field. The tumor reveal mitotic, necrotic areas, and really looks like high-grade tumors. So this was our first thoughts about this tumor, round epithelial yeast, poorly differentiated carcinoma, or myepithelial carcinoma. This is very rare in gastric. Gastrointestinal clear cell sarcoma may be a possibility, round cell sarcoma, lymphoma, hematolymphoid neoplasm, smart CA4 or smart CAB deficient tumor, nuclear sarcoma. So I don't know how to call this tumor, because for some organ is sarcoma, for another is carcinoma, for another is undifferentiated nuclear tumors, melanoma, and of course also thinking in rule out GLI1 altered neoplasm that can be in gastric location, but this is not a morphology usually for GLI1. And so Jason, I don't know if you have any additional opinion for any other histological suggestion?
No, I think you've really covered the options really comprehensively. I think on morphologic grounds, it's very difficult when you see a case with such sheet-like growth and uniform morphology that really doesn't look like a gist. So that's sort of where you start. Like, could it be a gist? Well, the morphology would be very strange. So then you open your possibilities to many of the other tumors that you listed. I think that given the fact that it has such a relatively demarcated interface at the periphery, lymphoma and carcinoma would be much less likely. So that would at least put many of the other mesenchymal neoplasms higher on the list. But beyond that, without immunohistochemistry, I think it's really it's impossible. I think it's great.
Okay, let's continue with the immunohistochemistry result. And you can see here, this is KIT expression. As you can see, the tumor reveals strongly and diffuse KIT expression with the internal control. But this was curious because in some areas, the KIT expression with like follicular pattern. I have never been seeing this pattern in this kind of tumor that you will see the final diagnosis at the end. But without doubt, the tumor was strongly and diffuse positive for KIT. Also, the tumor revealed Pachick cytokeratin expression. As you can see here, the Pachick cytokeratin expression. So, jumping again to H&E and with this immunohistochemistry, do you have any suggestion or opinion? You or the audience?
We need help from the audience. This is really unusual. Well, I think two things to consider, not necessarily for this case, but we know that KIT expression is quite common in melanoma. So just to have it somewhere on the list of things that can express KIT, melanoma is possible, and angiosarcomas can also express KIT.
Okay.
So, you know, if we were coming back to Enrique's case, it's possible that that tumor had some KIT expression as well. But this much KIT is very unusual in most other tumor types.
Okay, let's continue. So dog 1 was completely negative. So I guess that we apparently may rule out this mate, and this is SDH that was retained, and this is as Honda, chromogranin, synactophysin, that was all, as you can see here, negative. Node was also negative, melanic marker negative, WT1 was also negative, SMARCA4 was retained, and IN1 was also retained. So we can rule out many of these, at least many of these entities that we have already presented in this list. And interesting, this tumor was strongly and diffuse positive for ERT. You can see here the internal control, but the tumor really revealed a strong and diffuse ER positivity, as you can see here. So maybe we can rule out this entity that I have already put in another color, and maybe this is, I don't know, Jason, what do you think?
Well, I agree. We can cross off most of those.
Okay, let's continue. So this is the other staining that we performed. This is CD99. As you can see here, the tumor was strongly and diffuse positive for CD99. As you can see here, this is pattern is really very, very usual for Ewing sarcoma. This is strongly and diffuse and with sometimes Golgian staining. So this is very usual for Ewing sarcoma, and this could be fit with c-KIT expression. That is also possible in Ewing sarcoma. You can see here, this is strongly and diffuse. I think that when all pathologists see this CD99, also thinking first in Ewing sarcoma, I guess. So we also performed NK 2.2, and this was also positive for NK 2.2. Now this is interesting because at the beginning, Kate 2.2 is, as you know, is a target with WS-Fly1. The protein serve as immunohistochemical markers, but you will see this K because the gene fusion was not with flies. And so this is the result of molecular, because we're thinking about Ewing sarcoma in this case, of course, with request fish analysis. The fish analysis revealed AWS translocation. The molecular biology by RT-PCR, in this time, we didn't have in our hospital the NGS panel for gene fusion, and Professor John Barbosa and Samuel Navarro kindly performed the RT-PCR and revealed the WS-R fusion, and this could be explained the strongly positive R. But just to remark that sometimes a proportion of tumor with R fusion cannot reveal RWS translocation, so that is always important to keep in mind. So this is a follow-up of the patient. The patient was treating with adjuvant therapy with Bacchia treatment. That is the usual treatment for Ewing sarcoma. And at this, so this was a PET scan done after surgery to be sure that it's a primary gastric tumor and there was no tumors in another place. And with 30 months of follow-up, the patient is free of disease with no metastasis. So this is the Lizo's case described as gastric Ewing sarcoma. This is in the 14 case. And this is the 2 case that in this paper have not described it. 1 case in 2022 and 1 case, that is the case described in this paper. And only case, as far as I know, reveal the same translocation. I'm not completely sure that all these cases represent real Ewing sarcoma because they have only, in some cases, only AWS fish, no available molecular translocation. Some maybe represent another entity, I don't know, who knows? But my take-home message, no, because it is not Thailand. Maybe in Thailand, take-home message would be nice, but our proposal take-home message for gastric Ewing sarcoma that could be that cytokeratin expression could be present in around 20% in Ewing sarcoma, but it is very rare MA co-expression. The second is approximately expressing in up to 40% in Ewing sarcoma and can be diffuse, but without DOT1 expression. Curiously, it's also reported second mutation in Ewing sarcoma in a very low percent of case. We guess that when we are dealing with a round cell yeast, that is very rare. We have to always roll out or thinking about alternative neoplasms like hematolymphoid, gastrointestinal, neuroectodermal, Ewing sarcoma, will likely one, etc. And finally, a strong and diffuse CD99 with lack of DOT1, that's under melanic desmin expression and AWS rearrangement. I think that is very in favor of Ewing sarcoma. Thank you for your attention. And I would like to know your opinion or comment about this case.
Yeah, this is a beautiful case, and it shows us several important pitfalls to be aware of. I think keratin expression is quite well known, so most people who encounter sarcomas are familiar that some Ewing sarcomas are keratin positive, but KIT expression is much less well known. In fact, the very first paper that I wrote in soft tissue pathology with Chris Fletcher when I was a fellow, more than maybe 22 years ago, we were just doing a survey of KIT expression in soft tissue tumors. And in that study, we found 20% of Ewing sarcomas were positive. But even in that study, looking at lots of different cases, I don't think I have seen a case that has this much expression of KIT. Your case is really amazing how intense and diffuse the KIT expression is. So it's a great pitfall. And ERG expression as well. We have seen a few different studies looking at the correlation between the fusion status and ERG expression. Mm-hmm. And when you see strong nuclear ERG, the correlation is quite good. I did a study many years ago with Pankras Hogendorn and the group from MD Anderson with Alex Lazar, and the correlation was quite great. So I think that's also a good screen for the 5% of Ewing sarcomas that have ERG fusions instead of FLI1. And it's a really tough case. I think it's, in a way, it's a little bit similar to Enrique's case in that the very sharp circumscription is so unusual for a high-grade sarcoma. You know, we think of angiosarcoma, Ewing sarcoma should be infiltrative. This is a tumor that really looks like it just kind of stops at the edges of the gastric muscularis propria. So it's just amazing. But I think that all the data you have beautifully illustrate that this is Ewing sarcoma, just with exceptionally rare presentation. I think I've only seen 2 cases of gastric Ewing sarcoma that I'm aware of. I have seen a few cases in the intestines. I had a case in the rectum where the pathologist was sure it was neuroendocrine small cell carcinoma, but it was Ewing sarcoma in a low anterior resection from a middle-aged man. So it's always something to think about. It's a great case.
Thank you.
Was this a recent case? Do you have any follow-up after you said that the patient was treated and you
Yes.
had comprehensive imaging, but no follow-up yet?
Yes, we have 1 year of follow-up, and the patient is free of disease.
Wow.
Mm,
Amazing.
mm.
Any other questions for Isidro? We have a couple of comments people really like the case, but I don't see any questions yet. Ewing sarcoma can arise anywhere.
Yeah.
It can arise in the skin, gastrointestinal tract, the kidney, anywhere.
Yeah. Mm. Mm. I'm looking for Sergio Jason because we would like to make a short presentation or for the advertise for the International Academy of Pathology from Cancun in next year, but I cannot find Sergio to be connected. He has sent me the video, but I can't download the video. So maybe okay, perfect. Thank you. Oh, fantastic.
I would like to invite everyone to attend the Congress of the International Academy of Pathology that will be held in October in Cancun, Mexico. And I'm going to show you this video. This is very quickly. Thank you.
We can see Sergio the video. This is not still open.
Sure.
No.
Let me.
Can you click on the?
Perhaps you need to share a different field, maybe share the program instead of this screen.
Mm.
Can you see the video or no?
No. We see only the version EIP, but we can see the video is not running.
Let me.
Estamos viendo una carpeta.
We're not seeing the video either, Sergio.
Oh.
Sorry.
I don't know, sometimes.
Now we can.
Yeah.
Yes. But no audio if there is audio. but it looks amazing. We all want to come.
Okay, thank you. Thank you. You have a version. We will send you, Isidro, the video,
Okay.
probably for the next session of the.
Okay. Okay, no problem. In September, in September is the next session, because in August it's very difficult to recruit for this type of section. So in September, without problem, you can send me before the video, and I can show, and you can make a short presentation with the advertise if you wish.
Okay, we already
Okay.
sent the video.
Okay.
Thank you very much.
Okay.
Well, the invitation is open for everyone, and the program for soft teaching is very interesting. Professor Jason Hornick and Fiona McLean will be in charge of the soft tissues symposiums, and we will have also a very interesting seminar, a slide seminar for bone and soft tissue tumors.
Okay, great.
Okay.
Sergio, if you want, we can. Do you know that IMPERAS has its own social media, Twitter and Instagram? If you want, we can share the meeting, the IMPERAS social media, especially the sessions on bone and soft tissue.
Thank you very much. I will send the information and the videos for you can share with all the members of the IMPERAS. Thank you very much.
Okay, thank you.
Okay. Thank you very much, Jason, for your time, and to all the speakers, as well as to all the attendees. I think that was a very nice session. We usually run in this session in a monthly basis. If you want, we can send you. I know that you are very busy, but we can send you the link, and if you have some time, so someday you can join us in another time. So
if you think that's interesting, you can share with your residents or whatever. It's open, free, and open. Sometimes we speak Spanish, but
I have to learn before the next session. Well, thank you so much.
Okay. Thank you. Thank you.
bye bye, Jason. Thank you.
Bye bye.
Thank you.
Bye bye. Thank you.
Bye bye.
Bye bye.
Bye.